Welcome everybody to Wellbeing Health and Youth Centre of Research Excellence in Adolescent Health webinar series. I'd like to first off introduce myself. I'm Professor Rachel Skinner and I'm the Deputy Director of Wellbeing Health and Youth. I'd like to acknowledge the funding support from the NHMRC and our research partners in universities across Australia. And I'd also like to say that we acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture, that we pay our respects to their elders past, present and emerging. And so I'd just like to bring your attention to Wellbeing Health and Youth Community of Practice website, where you can access any updates. It's for clinicians, policymakers and researchers, any updates on literature and policies and output. And also all of our seminar series do get eventually uploaded onto that if you missed any. So just to orient you to, for people who've not been on this before, you'll be muted throughout and your video is switched off. But if you have something to say, please put it in the chat and type it into the chat and say hello to other people who are also who are on the audience as well. And just as we go, and we'll pick them up at the end, and the speakers will respond to them at the end of the webinar. So we were all privileged to hear from Professor Claire Vajdic. Claire is a Professor of Epidemiology at the Kirby Institute, University of New South Wales. She's a cancer epidemiologist and population health scientist, and she specialises in the use of integrated data sets to inform equitable health policy, practice and patient outcomes for high risk and disadvantaged populations. And is leading a great, exciting program of research I think we're going to hear about today. And Dr. Kristen Davies, who I think lots of people on this call know very well. She's a research fellow at the University of Sydney, president of the Australian Association for Adolescent Health and ambassador for 2010. She has expertise in child and adolescent health, vaccination for young people, gender, sexuality and sexual and reproductive health, health education and comprehensive sexuality and relationships education. And she's committed to using evidence-based research to close the gap between research and its translation into policy and practice. So we're also hugely privileged to hear from Kristen today. And Dr. Sally Sweeney. Sally works in private general practice and is a VMO with the Hunter New England Voluntary Assisted Dying Service. She's also medical lead at Family Planning Australia Research Centre and a conjoint senior lecturer with the School of Medicine and Public Health, University of Newcastle, and she has over 20 years clinical experience and expertise in sexual and reproductive medicine and clinical research. So great, also very, very privileged to hear from Sally today. What a great panel. And just introducing Include Cervical Cancer Prevention for All, WH&Y webinar. So I'll hand over now, I think, to Claire, who's going to be taking us off. So thank you, Claire.
Thank you so much, Rachel. It's a privilege to be here today, along with my colleagues, Kristen and Sally. So thank you. So the Include study, the full title is Identifying Primary Care Opportunities to Enhance HPV Vaccination and Cervical Screening for Priority Population Groups. We're very fortunate to be funded by the Commonwealth Government through their MRFF scheme to conduct this work that we'll be talking to you about today. Here's an outline of our presentation, covering off briefly what is human papillomavirus, the cause of most cases of cervical cancer, an overview of the 2 cervical cancer prevention programs in Australia, HPV vaccination and cervical screening. What do we know about the current coverage of these programs in Australia, the evidence gaps, and then an overview of the Include study and our proposed engagement, including our proposed engagement. Very fortunate to be joined by a multidisciplinary team on this particular project, multi-institution, multidisciplinary, people who've been working for several decades in cervical cancer prevention in Australia. And also very lucky to have some guidance and direction through our partner organisations, including the Wellbeing, Health and Youth Centre for Research Excellence, various colleges, federations and clinical groups, as you can see here, and governments as well. So I'll now hand over to Kristen and I'll see you in a moment.
Thanks so much, Claire. It's a delight to be here. So I'll just give you a little bit of background about HPV. I know some people might have some knowledge and some people might have less knowledge. So HPV is a small double-stranded DNA virus and it infects skin or mucosal cells. And it belongs to the papillomavirus family, in which there are approximately 200 types of HPV that have been identified. And there are about 40 HPV types, genotypes of genital HPV that can be transmitted through sexual activity and direct skin-to-skin contact. It's a common sexually transmitted infection with up to 90% of sexually active people who will acquire genital HPV in their lifetime. And it's acquired through skin-to-skin contact and spreads through breaks in the skin, so not through blood, semen or saliva. HPV affects all genders, and several high-risk types can cause cervical and other HPV-related cancers. Our immune system clears most types of HPV infection. However, persistent HPV infection can change normal cervical cells to cancer cells, and that can happen over the period of about 10 to 15 years. So got a fun slide here. While HPV infection is typically, as I said, asymptomatic and can resolve spontaneously in about 70 to 90% of cases, high-risk types can cause cervical, vulvar, vaginal, penile, and oropharyngeal, that sort of mouth and throat cancers. So we can see that about 99% of cervical cancer is caused by HPV. About 90% of HPV can cause anal cancer. Approximately 10 to 60% can cause oral pharyngeal cancer. 50% can be caused by of HPV can cause penile cancer, and about 40 to 50% of HPV can cause vulval and vaginal cancer. So HPV vaccines combined with cervical screening in women and people with a cervix can reduce cervical cancer incidence and mortality. And HPV vaccination should ideally take place before a person becomes sexually active. And that's because vaccination provides optimal protection before exposure to HPV. So getting vaccinated before sexual activity has commenced, and at a time when the body produces more antibodies, such as during adolescence, is recommended. However, while a sexually active person may have been exposed to one or more types of HPV, it's unlikely that a person would have been exposed to all types of HPV that the vaccine protects against. So it's still of great benefit for a sexually active young adult up until the age of 25 or before their 26th birthday. So now we've got a poll, and are you going to launch that, Claire, or do I just move? Oh, okay, great, fantastic. So we've got a poll there, and it says, I'm 22 and I've missed the HPV vaccine at school. Can I still get vaccinated for free? You're all ahead of me, or a number of you are ahead of me answering this. So if everyone could jump on and do that, that would be fantastic. Okay, still going up. I might, if I move it on, do I get to share the results?
I can see the results there when I click on the box. Yes.
Yeah, okay, great. So we've got about 68% of our audience have said yes. We've got about 10% of the audience that have said no. A few have said it depends, and a few have said I'm not sure. So I think the answer is yes, you can still get vaccinated for free, or at least it's government subsidised. And we might talk a little bit now about where you might be able to access that vaccine. So HPV vaccines combined with cervical screening in women and people with a cervix reduce cervical cancer incidence and mortality. And so it's really important to have that. But in Australia, HPV vaccination is free or government subsidised for people aged 19 to 25 or before your 26th birthday. And most people require 1 dose of the 9-valent HPV vaccine. People with immunocompromising conditions are recommended to receive 3 doses of the 9-valent vaccine. And most young people receive the HPV vaccine through school-based programs in Year 7, and that's when they're approximately 12 or 13 years of age. If the vaccine is missed, young people can receive a catch-up vaccination through community-based programs. And the HPV vaccine is also available through a GP, a pharmacy, a community health centre, a local council or immunisation clinic, and also an Aboriginal medical service. It's not recommended for those who may suffer from anaphylaxis or during pregnancy, but can be administered while breastfeeding. And so I'll just take you a little bit through the school-based program, or where we can actually access the vaccine. So most young people access the vaccine through the school-based program, and the vaccine is available for young people 9 to 19 through the school-based program, although most commonly it's available through Year 7. So the majority of young people get it through Year 7 when they're 12 to 13 years. The vaccine is also recommended through community-based programs, and young people aged 9 to 13 who are accessing the vaccine through community-based programs do require parental or guardian consent, and those aged 14 to 18 can access the vaccine through either a GP or Aboriginal medical service. And they can also, if a young person is determined GILEC competent by a GP, no parental or guardian consent is required. And the HPV vaccine is also available from pharmacists with parental or guardian consent for young people 14 to 18. Young people aged 18 to 25 can access the vaccine through a GP, an Aboriginal medical service, pharmacy, community health centre, or local council and immunisation clinic, and no parental consent is required for those 18 and over. So changes a little bit depending on where you receive the vaccine with regard to the setting. So I'm going to hand over to Claire now. Thank you.
Thank you so much, Kristen. So as Kristen mentioned, we now have a single dose vaccine, but you might recall that when it was originally launched, the HPV vaccine was recommended on a 3-dose schedule, and then it changed to a 2-dose schedule. And we're now on a single dose schedule. That's because a range of clinical trials in multiple different countries were able to demonstrate that a single dose is as effective and as durable as 2 or 3 doses. And that's a range of scientific and clinical evidence that generated that data. And ATAGI, the group in Australia, reviewed that evidence, and their recommendation aligns with that by the World Health Organization and many other countries. So it's on a very solid basis that is a single dose vaccine will work for healthy young people. As you can see there, it's not a therapeutic vaccine, but it may prevent subsequent disease in those with previous disease. In addition to that effectiveness evidence, another reason to switch to one dose is that it greatly simplifies the administration of the vaccine program and is lower cost for government and young people as well. So can introduce new opportunities for vaccination, and that's why we've also seen that expansion to pharmacies, and which weren't there in the beginning. So it is as effective, and we're more likely to reach the target coverage of 90% across the community with a single dose. So it's very strong evidence base for this change. We have a couple more polls. If you wouldn't mind clicking again onto the right-hand side, and we have another scenario question to pose. This scenario is, I'm 22 and I missed the HPV vaccine at school. Can I still get vaccinated? No, sorry, that was the first one. Sorry, the second one, reading in the wrong order. I'm a 30-year-old woman and I had the HPV vaccine. Do I still need to have a cervical screening test? And the options are yes, no, and I'm not sure. A 30-year-old woman who had the HPV vaccine. Do I still need to have a cervical screening test? Got around 80% of the audience have answered there. And the correct answer is being selected by the majority, and that is yes. Because the vaccine does not prevent infection of all types of the human papillomavirus. We have a third poll, and I'll just share that with you now. This is the final one. It's a question. Is a self-collected cervical screening test as good as a clinician-collected test? And the responses available to you are yes, no, and I'm not sure. Are the self-collected cervical screening test as good as a clinician-collected test? An interesting range of responses there, and I think it's really helpful that we're having this webinar to talk through thinking behind the responses. And the answer is, and Dr. Sweeney will go through the reasons for this, but yes, a self-collected screening test is as good as a clinician-collected test. And with that, I will pass you over to Sally. Thank you.
Great. So for those, I guess, in the room who may be not clinical, a bit of an overview of what the current cervical screening program involves. So since December 2017, screening has been offered to all people with a cervix aged 25 to 75. And the test is covered by Medicare for all Medicare card holders, but depending on what setting you're having your screening, there may be various fee structures in place. So if you're attending a private general practice, there may be a fee. If you're attending a public family planning clinic, it may be bulk billed. So there is some variability in costs there. Since the 1st of July 2022, we have had the availability of universal self-collected screening, which means that all people eligible for a cervical screening test now have the option of having a clinician collect screening, which in that graphic is the right-sided column there, which involves a clinician using a speculum to examine the cervix and take the swab directly from the cervix, or a person can elect to have a self-collected swab, or the terminology is sort of in the process of changing to something called a self-swab, where a little cotton tip is inserted by the consumer into the vagina at just a couple of centimeters, and both tests look for the presence or absence of human papillomavirus. The advantages of a self-collect is that it can be done in multiple places inside the doctor's office, in the privacy of home. It doesn't require a speculum examination, which can be uncomfortable and invasive in certain circumstances, and gives the person somewhat more control over their screening. The disadvantage is that if a HPV result is returned positive, you do have to return to the doctor for a clinician examination to then determine liquid-based cytology and the need for further triage of your result. So some people, when they hear that, do elect to go straight to the clinician collect to avoid the need for a return to clinic. But the main thing is that we now see choice, and that's been a real game changer in moving towards elimination and trying to get never and under-screened people into the screening program. And just referencing that poll there, the reason that both self-collect and clinician collect are both equally good, equally sensitive at detecting HPV is that the test is designed now to detect HPV. And if it's present in the cervix, it'll be present in the vagina. So whether we're using a swab that is taken from the lower genital tract or the swab taken from the cervix, both are equally as good at detecting HPV. And the reason that has come about is that the testing technologies, the PCR testing, has improved to the point where it's a very advanced and good performing test. Okay. I tried to move the slide along, Claire, but I pressed the wrong button. So I might need you to, oh, there we go. All right. Now, I guess the Include project is part of a number of pieces of work being done in Australia to achieve the ultimate goal of elimination. So globally, we are working towards elimination of cervical cancer, but there's some gaps to be closed. And one of the projects that I was involved in to sort of help identify those gaps was looking at a survey of clinicians. And just as in our poll there of all of you in our audience today, the question around whether self-collected is as good as a clinician collect, we saw that the same concerns were present among clinicians. So in the first quarter of 2023, I conducted a survey of clinicians who conduct cervical screening throughout Australia. We got 631 responses, 581 made it to final analysis. One of our priority populations in the Include project is our Indigenous Aboriginal Torres Strait Islander population. One of the problems is that we can't identify specifically from the data Indigenous status, and only 22% of the clinicians surveyed in this study were actually identifying routinely on the request forms whether or not somebody was of Aboriginal or Torres Strait Islander status. One of the problems with the initial move to the option of universal self-collected screening was that there was a lot of confusion among clinicians around pathology providers. So, for example, sitting here today, I've got 3 labs that I could potentially send a swab to. Each lab has a different swab type that they would use for a self-collect screening. So at the start of the program, there was problems with samples being rejected because they were on the wrong swab, clinicians not sure what swab to collect. So in our survey, there was still 10% of clinicians unsure around swab types. So that was a bit of a logistical problem in the early days of the self-collect rollout. Only 84% of the clinicians we surveyed felt that self-collected screening was appropriate for people presenting for cervical screening. I'm hoping that now that we're another 12 months down the track, that is changing. And interestingly, the responses reflect a little bit what our poll showed is that only 25% of our clinicians surveyed found that they either 25% agreed or strongly agreed that self-collected testing was as accurate as clinician collect. So there was a fair bit of concern early on in the piece that maybe a self-collect was not as accurate. One of the really game-changing aspects of self-collect is that it would allow cervical screening to be offered outside of a clinic room. But there's still a bit of work to be done in acceptability of that. So again, in our survey, only 30% of respondents said that they would consider offering self-collected screening by telehealth. The remainder said only in exceptional circumstances or never. And when we think about breast and bowel screening, you know, we've got buses, we've got mail-out bowel kits. So, you know, cervical screening still very much clung on to that clinical setting that I think there's some work to be done there. And interestingly, though, we did see that there has been some change. So one of the questions we looked at was that early on in the piece, self-collect was only offered to people who were under-screened or never screened. And so we looked at who had offered self-collect screening before it became a universal option to who had offered after. And we were seeing that there was a change. There was an increase in the number of clinicians who were offering self-collect. So that's reassuring to see that there is change happening. Sometimes it's hard to change clinician practices. So we're a work in progress. A second body of work, again, in the Include project, one of our priority populations is people with an intellectual disability. So Screen Equal is another NHMRC project that I'm an investigator on, and it is a project to improve cervical screening among people with a disability. That project is still underway, but stage 1 has been completed, which involved qualitatively exploring facilitators and barriers to screening participation among this priority group. And again, we identified some gaps that Screen Equal and Include will hopefully work together to close those gaps and work closer to equitable elimination of cervical screening, cervical cancer. But we did find that there were some glaringly incorrect assumptions being made by both carers and clinicians alike that people with an intellectual disability did not require screening because there was this underestimation of sexual activity. There was this feeling that people with an intellectual disability were not sexually active and did not require screening. So one of the take-home messages for our work was that there was this call to sort of uncouple screening eligibility from sexual activity and make it more being related with the presence or absence of a cervix, really. Another big message was that clinicians really need to be at all times maintaining a trauma-informed approach, and that this group were a group who have high rates of sexual abuse. We need accessible information, and again, moving screening outside of those traumatizing clinical settings. There were consent issues, and rapport with a clinician was a really important take-home message as well. So that's just a little bit of a snapshot of some of the gaps identified in some other projects working in the space that will be reflected in the work of Include as well. And there's just a little summary slide of some of the barriers to uptake of both screening and vaccination there. In the interest of time, I won't spend too long on that one. So back to Claire there to discuss our elimination strategy targets.
Thank you, Sally. So, yes, last year, the Australian government launched the cervical cancer elimination strategy. It has 3 targets here. The goal of 90% coverage for all eligible people to be vaccinated with human papillomavirus, against the human papillomavirus, 70% of eligible people to be screened every 5 years, and 95% of all eligible people to be receive optimal treatment for pre-cancer and cancer. And the data that we have to date shows that Australia is well on the way to eliminating cervical cancer under these measures, and could be one of the first countries to announce that. However, the data that we have is at a very high level, as you can see here, in terms of jurisdictions and in terms of socioeconomic regions and rurality. And it's quite possible that we may reach those targets at a national level, but not for high-risk population groups in our community. And that without the data, that we'll have continuing and ongoing inequity in access and in actual vaccination and screening for these high-risk individuals. So we're on the way here for HPV vaccination coverage. This was 2022. I understand there's been some changes post-COVID, and we may see a decline over time since that point. The news is more promising. The data is more promising there for cervical screening. uptake. So we already exceed at a national level or at the state-based level here the target of 70% screening, but there is still a gap, of course, and that is a nominal target, and the idea would be as many women as possible who are eligible are screened in Australia. The issue being, underlying the data that we have had to date, is that we do not have visibility of the high burden groups. There's certainly no presentation of data that on people who belong in 2 or more of those groups. For example, someone living in a remote area of Australia with a disability, or that group of people, the data is just not available. And the people on the ground really need very local data on which they can act, change their strategies, change their clinical practices, have purposeful policies. In the past, we were restricted to analysing single data sets that could have missing or inaccurate data, and it was typically collected for administrative purposes only, and none of it self-reported. And there was never an ability to look at social determinants of health at a person or a household level in the past. So that's where the Include project comes in. So our aim is to help Australia achieve equitable elimination of cervical cancer by identifying and reducing the barriers to access to immunisation and cervical screenings tests in primary care. We have established a governance framework that includes members of affected community groups, policymakers and clinicians. We're also at the stage of identifying the best practice way to identify these high burden groups in the available data. And then we'll be able to estimate screening coverage and determinants, and ultimately to make this data available and accessible for those population groups and in a dashboard, in a digital, what we call a digital navigation tool, so that data can inform and be translated into new strategies, practices, resources and policies. As Sally mentioned, we have people with disability is one of our priority population groups. The other 4 groups are shown here on the slide. And importantly, because we're going to be working with data at the level of the individual, we can look at the people who do intersect these groups and generate that local knowledge. We've been very careful with our governance so that we can achieve co-design and genuine co-creation throughout this project. The data that we're using is maintained by the Australian Bureau of Statistics. When they established it, they didn't have a particular Indigenous governance framework around that data. So our Aboriginal and Torres Strait Islander leads on our project have developed one to introduce some safeguards for Aboriginal and Torres Strait Islander communities in our project. So all decisions to do with the analysis and reporting of data about Aboriginal and Torres Strait Islanders will be controlled by Aboriginal and Torres Strait Islanders through our internal working group and an external reference group that's based at the ANU, where Associate Professor Lisa Wapp is based. She's our co-chair, along with Associate Professor Kalinda Griffiths. And we have representation of community groups, community members and clinicians across these other working groups shown here on the slide. We thought we'd pause here and just do a bit of a recap, just so everyone's on the same page, to tell you a bit about the types of data that are routinely collected about us here in Australia. So whenever we're diagnosed with a specific notifiable disease, that is notified to a register, for example, cancer and some communicable diseases. Also, when we die, when we attend a GP, a hospital, emergency department. So there's records kept of these events, if you like, or episodes of care. also collected and that we have ready access to. And I saw that there was a question in one of the chats about, I'm not sure if I was vaccinated. You can actually look up your vaccination history on the MyGov website, or your app if you have a smartphone. You can check your vaccination history on the dates and the type of vaccination that you had. Also your Medicare claims, your cervical and bowel screening history, and other government records. So it gives you an indication of the types of data that are collected. And what we're doing in this project is bringing them all together. And a tool that we use for that is data linkage, and that's the bringing together of information from different sources about the same person, event, or institution. And the way that is done by a third party that does not hold at the same time identifying information and that episode or event information about us. So basically they have our name, address, and date of birth from a number of different data sets and join them together. And then the content data from that, from those different data sets can be joined in a separate place and accessed securely by the researchers. So it is safe in what we call the content data, and the identifying information is never stored in the same place, never held by the same person at the same time. And that there are, the content data is closely scrutinized for its potential breaches of privacy and confidentiality. So you can be assured that there's very, very good controls over access to this data, analyses of this data, and reporting of this data, because privacy and confidentiality of individuals and institutions is essential. So this is a visual of the data that the Australian Bureau of Statistics is collecting in their PLIDA data asset. So that's person level integrated data asset, a bit of a mouthful, but you can see it includes data from a number of domains, including health, but including social data that has not routinely been linked with health data before. So this is another game changer in Australia and our ability to better understand the uptake of different health services. So you can see there, it's got Medicare benefit schedule data, pharmaceutical benefit scheme data. So whenever we're going to a GP or filling a script, that data is there, together with Australian Immunisation Register and census and those other administrative data sets. So what the ABS has done is that they link these data sets and share them with researchers. And this is called an enduring data linkage. And it means that we can have access to the most contemporary data that is available. And it's longitudinal, it's enormous, it's over time. So we've got each of those records at an individual level so that you can look at before and after a diagnosis, for example. And this data is accessed in a secure remote analysis laboratory by trained and verified analysts. And any information that's brought out of that environment undergoes review by the Australian Bureau of Statistics. So it's really a secure environment and you can have confidence in that. How are we going to identify members of population groups? There are multiple different approaches that we could take. As you can see, we've got, we could have multiple flags that someone belongs, for example, to the group of people with disability. And we're going to be working with community, working with data scientists to understand the best approach that we should take to adequately identify and correctly identify someone as belonging to that group. Because there's no existing approach that's sort of fit for purpose for this collection of data sets. And this is the phase of the project that we're in now, and it's incredibly interesting and exciting to be working with community to understand how they would like to be represented in the data. What will that digital dashboard look like? So we're aiming to have the latest estimates of coverage of HPV vaccination and cervical screening, not only overall, as you've previously seen, but for the population groups and at a local level, so that different policymakers and clinical services can act, showing the trends over time. We will expand that to also include specific scientific projects. For example, we're looking at the characteristics of people and the healthcare opportunities that were missed, for example, for vaccination in the first instance, and then secondarily to look at the characteristics of those people that are being missed, for example, for catch-up vaccination because they're simply not attending primary care. So we can ascertain that level of information. Looking at determinants, including social determinants, and the dashboard will be interactive so that you can pull down and create a tabulation or a visualization for your area or your population group of interest. We'll also be including a lot of information there for those people who are interested in understanding how we've generated the data that's there, what's underlying the classifications, and optimizing the different dashboards for different users. And these are the people that we are aiming to influence, obviously, community groups, clinicians, primary health networks, community-controlled health services and governments. So using our data to then generate targeted and tailored strategies to people who are missing out, education resources for healthcare providers as they're needed, but specific to priority population groups, and even working towards identifying gaps in workforce where we can. Where are we up to right now? As I mentioned, working on optimizing those population classification definitions. It's likely, for example, that we might have a different definition for adolescents than we would for adults because of the different data sets that are going into, that are providing flags for those different population groups. We're conducting a comprehensive quality assurance. As I mentioned, many of the data sets have missing data, and we need to understand how that might bias our findings. We also know that when we link one data set to another, that some people are not in some data sets and they fall out when you require them to be linked. So we need to understand the characteristics of those people and whether it's going to be influencing our findings. So that's the sort of phase that we're up to now, expanding the team and aiming to generate the first results in August, which is incredibly exciting after all this time. So we're also calling for new collaborators of any age from community and clinical practice, as are some collaborators of ours here that I just wanted to give a plug for at the University of Melbourne. They're doing some work on improving cancer prevention for young people in Australia and seeking to establish a youth advisory group. So if you happen to fit the criteria shown here on the slide and might be interested in working with them, they're a fantastic team. We're all working towards the same goal of maximising cancer prevention across Australia. And so I would encourage you to join that team, and just finish up by thanking you for listening and looking forward to answering your questions and comments that we can see there in the chat. Thank you so much.
Thank you so much, Claire. That was, and Kristen and Sally, that was just a fabulous presentation, and I really enjoyed it. I'm sure I'm a bit biased, but I think that everybody else would have agreed. We've got some questions, so I'm going to go to some of these questions, and I've got some myself too. So first off, we have Nicola. Sorry, this is for you, Kristen. Does the fruit slide mean that that percentage of these types of cancer are caused by HPV, or the other way around?
Yes, that's right. Yeah, I'm happy to jump in there. Yeah, yes. So the proportion, so it's like 90% of cervical cancers are caused by human papillomavirus. Yeah, that's correct.
Great.
We can't hear you, Kristen.
Your audio's gone. I don't know, Kristen, if you want to jump off and jump on, but anyway, we could move on to the next slide. Is this I'm sorry, not the next slide. What am I saying there? We didn't answer this one. I'm trying to remember if I got the jab in school. When was the broad-based school program established? And if I remember correctly, women and girls got it first, yes. So I'm sure, Claire, you can answer that.
Yes, established in 2006, I believe.
Yeah,
2007, thank you. And yes, women, girls, school-age girls got it first. But as I mentioned, if you have a MyGov account, you can check your vaccination history by logging directly into the Australian Immunisation Register. So hopefully you won't have to work that out by process of reduction, but you can actually check and act on that.
And just to follow on from that, just say they did check and found that they'd only had 1 dose or 2 doses, but back then it was a 3-dose schedule. What would be your recommendation?
By all means, jump in, Sally, but given the current evidence, a single dose would be deemed adequate. The 3-dose schedule was implemented first because that was what they thought would be needed, but they've since found through a range of scientific studies that a single dose will give you adequate protection.
Okay, great. Thanks. I'm not sure if Kristen or Sally wanted to add anything. Now you're back, Kristen.
Nope, Claire nailed it.
Kristen, you happy? No, sorry, you try again. I'll kick.
Can you hear me?
Yes.
Okay, great. Sorry, I missed that last question, but I could go back to Nicola's. I think Claire answered it really well, but just to say, yes, it's 99% of cervical cancer is caused by HPV, 90% of anal cancer is caused by HPV, so that all of those percentages went in that direction. And I'm sorry, I just missed the question that was asked then, so I'll leave it with Claire and Sally.
That's fine. So next question that we have is, could a self-collected sample from the vagina be used by practitioners going forward, replacing one of the most the more invasive speculum-assisted cervical samples? That's for Sally.
Yeah, so we already do a bit of this, I guess, in an informal way, in that sometimes you might try to do a speculum examination and for whatever reason it's not tolerated. So then you convert to, I guess, a clinician-assisted self-collect, in that we will just pop the swab in. Or there are some people who, for whatever reason, are unable to do a self-collect swab, if they've got arthritis in their hands, or they just don't have the dexterity, or this came up in our disability sector work, in that the option of a clinician-assisted self-collect is something that may be widely used. So yes, if we're wanting to open up screening opportunities, then absolutely you can be doing this sort of clinician-assisted self-collect. It would still be deemed a self-collect on the request form, and just keeping in mind that if the sample doesn't come from the cervix, you wouldn't be able to have a reflex liquid-based cytology on it. So again, if there was positive HPV detected on that, there would still need to be that cervical sample taken to allow liquid-based cytology. But yeah, absolutely.
Yeah, that's very exciting. Incredible innovation. So I have a question for Claire. So how good is the PLIDA database? So how good do you think it's going to be in identifying the priority populations? I know that you talked about different ways of looking at it, and that might be, I think the example you used was disability. So what about, how good is it, how sensitive would it be? And I mean, and for other priority populations as well?
Yes. For disability, I do believe we're going to be able to classify the broad type of disability, whether it's sensory, physical, psychosocial, for example. it looks like it's going to be a little bit more challenging to identify the extent of disability. But we're working on that with a great team out of the University of Melbourne, Zoe Aitken and her colleagues there, who've been working with the linked data sets that make up PLIDA for many years now. So we know we're going to be able to do the best job that we can with the data available. Working with existing records that have been collected for a different purpose always means that they're not going to be perfect for every purpose, every research purpose going forward, but better than anything we've seen before in having self-reported information there through surveys, as well as administrative data that might be reported by someone else. So I do think it is going to be, I know it's going to be an improvement above what we've had access to in the past for disability, which has largely remained invisible. Aboriginal and Torres Strait Islander, where there's been a large proportion of records that have had missing data that can be filled because we've got other data sources that we can draw it from. But we will be taking a very careful approach to interpret the data with the caution that it needs should there be issues in relation to missingness, variability over time, and records that are not linking. What is different about those individuals, and is that biasing our finding and interpreting that accordingly?
That sounds incredible. I mean, I think that, we're just going to learn so much about how to identify these groups, so priority populations within big data sets, and, myself thinking about my role as medical director of priority populations at the Sydney Children's Hospitals Network. We, that is something that we really need to think about how we do that too, is collecting, identifying within our patient cohort those that belong to all priority populations. So, we have quite a few priority populations so that we can make sure that we provide, better healthcare. So I can just see, the incredible advantage that this will bring. It's just amazing. So I did have another question, and that was about whether or not you'll be doing some linkage around cervical cancer, linking the HPV vaccine to cervical cancer rates, and you're looking at differences in cervical cancer, burden of cervical cancer and other potentially other HPV related cancers, and linking that to vaccination and screening. So things that have been challenging today.
Yes. You saw that the cancer registry data wasn't yet in PLIDA, but ABS are working on that. We do know that the cancer registry data that's held at the Australian Institute of Health and Welfare is not contemporary. So we really do need other ways of working as well, so that Australia can be the first to say, oh, we have eliminated cervical cancer. So we are working on that. It is a challenge, but the legislation is in place to enable that. What we will do is make all of our statistical code, our syntax, available so that it can be applied to other screen detected cancers, so breast, bowel, and in the future lung, so that other groups don't have to reinvent the wheel. We do know that the algorithms that we will come up with will necessarily have to change whenever new data sets are brought in, because it brings in new information that may change someone's status of whether or not they fit in a priority population group. But we want everything that we do to be accessible, contestable, and reusable. Yes.
Yeah, there's a lot of work involved. It's not just plugging another code and then getting it all out at the other end. Yeah, there's a lot of work. So we do have another question. So David's asking, have you considered LGBTIQA plus populations in your research? And if you have, what did you find?
We would love to, but at the moment we're limited to the last question in the ABS census, which you might like to step in here, Kristen, but I think it's unsatisfactory in that it just talked about cohabitation. many people would know that there was a lot of discussion around the nature of that question before it was launched. It wasn't satisfactory, and we're hoping that the next census will have an improved question, and that will allow us to report for that clearly high risk population when it comes to trauma-informed care and adequate care and accessibility.
Yeah, many of you will know I've advocated at the UN with regard to data collection for this population, and before the 2021 census. And I'm not sure if you're familiar, but if you do Google gender standard and ABS, you'll find some appropriate questions and ways that we can ask about gender and sexuality. And we're hoping that these sorts of questions will turn up in the next census. It's highly likely they will. So I agree, David, fingers crossed for the next census. And this is a really important population. And sort of anecdotally, we know that, especially with regard to screening, that queer women and trans and gender diverse people are likely to be underscreened, and there's a lot of work there to be done. So let's hope that if we collect the data, we can also do the kind of work that Claire is leading with that population as well.
Yeah, so I'm interested that they are applying that classification for sexuality and gender diversity in the mental health survey. And so the big Australian surveys that have been done recently, and whether or not you know that they could be included. So I know they're not a population, they're not total population, but
well, there is a survey of disability that is included in PLIDA, and ABS are interested in linking any data to improve the research potential of their assets. So that would be something for us to inquire about. So thank you very much for that, Rachel. I wasn't aware.
Doesn't include the adolescent age group. It's 18 and I think, or maybe it includes 16. But I'm not 100%. But as a household survey, that we would quite like to be extended down to the younger age group, but I'm not sure that will happen. Anyway, I mean, I think that's all the questions that we have. So thank you so much for such a wonderful presentation. It was just great to have the expertise across all of the different areas that we have on the panel. So that's just wonderful. And thank you for your time in presenting to our Wellbeing, Health and Youth community. And yeah, thanks to the audience for your contributions.
Yeah, so, thank you all.
Thank you.
And we'll see you again in a month's time.
Yes.
Great.
Thank you.
Bye-bye.